I'm very excited to welcome you to Beyond Complicated, Recognizing Complex PTSD in EDS, the first of many Lunch and Learns brought to you by ElevateRARE. This webinar is being co-sponsored by Chronic Pain Partners and the Connective Tissue Coalition. Next slide. Let me first introduce ElevateRARE. ElevateRARE is a brand new nonprofit educational think tank with a focus on education and programming for providers, caregivers, and patients. We're striving to raise awareness of the unmet needs of people who are undiagnosed, have rare and medically complex conditions, and the unmet needs of the providers who are caring for them. ElevateRARE was started by Donna Sullivan, the co-producer of the newly released documentary Complicated, a film about medically complex families. Several of ElevateRARE's board members are featured in the film. ElevateRARE is really about working to connect researchers, patients, and caregivers and providers to start rare but necessary conversations. I'm Kathleen Hoffman, and next slide. And I'm the Director of Communications and Research for ElevateRARE. My focus has been on creating health-literate content for caregivers and patients and providing programming to educate medical professionals about the complex unmet needs and gaps in care affecting families with rare diseases. So next slide. So why are we holding this webinar and having this conversation? People living with Ehlers-Danlos and other rare and undersupported conditions are spending years navigating a healthcare system that's just not designed for medically complex patients. For people with EDS, their diagnostic odyssey can last more than 10 years. Next slide. With all that they experience, the disbelief, medical gaslighting, among other trials, it's very little wonder that research indicates that as many as 1/3 of people with EDS have medical PTSD. So that's why we've gathered here with our guests. Mary Jenner is a nurse turned entrepreneur and podcaster. She's the founder of The Butterfly Pig, a family business creating medical toys to empower and improve pediatric patient experiences. And Vanessa Abrahams is a speech pathologist who is both a practitioner and a patient. Her memoir chronicles her experience with a rare condition and the survival of post-intensive care syndrome, which is a type of PTSD. Danielle King is a patient and healing practitioner. She shares her lived experience serving on the patient advisory boards of both the University of Virginia and Mayo Clinic's EDS centers. So now, without further ado, let me share the Zoom screen with ElevateRARE's founder, Donna Sullivan. Take it away, Donna.
Hey, everybody. Thank you so much again for being here. And thank you for that introduction, Kathleen. It's really appreciated. I'm really grateful for everyone who's taken the time to join us today. And as Kathleen shared, we founded ElevateRARE because there's a lot of kind of unintended harm and unique challenges that people that have medical complexity face when they're trying to access healthcare. I'm really excited about some of the speakers that we have lined up for you today because the goal is to really take a look at some of the uncomfortable things that are happening to patients. And one of them is unintended trauma in medical settings. So we have a really great presentation. But to give you a little bit of information, so I see some familiar faces in the audience, but for those who don't know me, my name is Donna Sullivan. I am the founder of ElevateRARE. I'm also a filmmaker, a writer. I'm the mom of 3 incredible kids who live with Ehlers-Danlos Syndrome. I myself have it, and I'm also a caregiver. Like many patients, my journey started almost 14 years ago at a time when nobody really understood even what Ehlers-Danlos was. There was very little information, let alone resources. And like so many patients, I was really fortunate to meet with others in the community. And that's where I gathered my strength and my information. And for 14 years, I kind of dove in as a volunteer in working in support groups, writing, blogging, and kind of became what I call mom with a big mouth. when you look in the rare disease space and you see parents, there's so many of us out there that when the medical system cannot help our kids, you will do anything you can to try to move mountains and move medicine for your child. So, I've met a lot of incredible people along the way. And one of the things about 9 years ago, when our New England-based mom nonprofit was starting to get inundated with kids that had Ehlers-Danlos Syndrome, and many of these families were coming to us, and they all had the very same story of not being able to get care, and these kids were incredibly sick. And that's when I decided to make this film called Complicated. As far as my advocacy goes, I am working as the Director of Patient Advocacy for Pathways to Trust, which is a tremendous organization that does medical education for clinicians and for medical students. I'm involved as a board member for the Connective Tissue Coalition. John Rodas, the founder, is a pioneer in Ehlers-Danlos Syndrome, and the CTC is working to find research that really matters and can try to help move the needle on getting better care access for patients. And as I said, I'm the mom to 3 incredible kids, so I not only know about, a lot of the challenges of EDS, but I live it. So as I was saying, 9 years ago, our nonprofit was really getting inundated, and the new diagnostic criteria for Ehlers-Danlos syndrome had come out, and it really just kind of seemed incomplete. It was really more about being bendy and wasn't really taking account of all of the multi-system problems with this condition. And keep in mind, 9 years ago, nobody was really talking about the word gaslighting, but our nonprofit was seeing, a lot of really unfortunate things and unintended trauma happening to these kids who were really struggling to get care. So I reached out to this film director. My mom's group decided we had to do something. We couldn't just keep watching the suffering. And there was no way that, people really could believe that this was happening in our top medical institutions. So we decided to make a film, and I had a background in production. I reached out to this amazing director, Andrew Abrahams, who had done a film at the time called Under Our Skin, which was about chronic Lyme disease and what happens to people when they cannot access care. The interesting thing about that documentary was he really got a lot of information and really presented also the medical side. What happens when there's medical controversy, when clinicians really don't understand a condition or have the tools and the resources to treat it. So we presented him our story, and after he vetted us and kind of believed us, right? Because it does sound a little hard to believe. We started filming, and it took us 9 years to make the film because it was really hard to get funding. Because once again, it was kind of hard to believe that these things are happening in our healthcare system. But those who live with Ehlers-Danlos know that it is. And the film has been, it's out on Apple TV right now, and it's also available for screenings. And we have spent the last year showing it at medical conferences, private screenings, patient groups. We're going to be showing it at the EDS Society conference, and really any place that wants to see it, because our film really dives into some of the really difficult and hard to talk about things that are happening in Ehlers-Danlos syndrome. And that was a real big part of the reason why we wanted to do this kickoff webinar and look at the issue of trauma. Because I'll tell you, our film is not an easy film to watch. I am so incredibly proud of the kids and the families who were brave enough to let our cameras in. That was a very scary thing to do for them, especially in some of their more vulnerable moments. But it does give the world a glimpse firsthand at the trauma that these patients are experiencing. And Ehlers-Danlos patients, we're we have a dynamic disability, so we can look very different. But what makes our trauma different is that it's pretty continuous. And so that's what I wanted to kind of, talk about here. When you hear these stories, one of the things that unites Ehlers-Danlos patients is a lot of them will have these really long stories about really unfortunate experiences and kind of bad things that happen in medicine. And I want to say, it's not that anyone's nefarious, but, these things are happening, and it's kind of a unifying problem in EDS. So it's Professor Rodney Graham, who unfortunately we recently lost, was really a pioneer in Ehlers-Danlos syndrome. And he put this quote out at a conference, I don't even know how many years ago. And it really resonated with everybody. And I feel like he was one of the first people to kind of not only validate Ehlers-Danlos syndrome, but to really validate the problem with access to care that not only patients were experiencing, but also clinicians. These doctors were being overwhelmed with patients who had all these conditions, and they really didn't have a clear diagnostic criteria, and they definitely didn't have any standard of care to follow. And so, I truly think that Ehlers-Danlos syndrome is the biggest story that medicine missed. And we're at a very unique time right now because research is advancing and there's starting to become more understanding of the complex nature of this condition. But that doesn't mean that we can just ignore, the history as well as a lot of the problems that this population endures. And that was really why we wanted to, once again, look at complex PTSD through the lens of the Ehlers-Danlos population, because our numbers are just so much higher. So I like to show this slide when I speak because it's my family. So not just because it's my kids, but just to kind of show what trauma, trauma doesn't always look like trauma. And when we walk into any appointment, we can look like anybody else. Now, we also could be in our wheelchair. We could have our cervical collars. We could have canes. Ehlers-Danlos is dynamic and people's conditions can wax and wane over time. But here's what you don't see when we walk into these appointments. And, I can tell you that because of this long medical journey that we had, that involved, we were averaging 9 to 13 weeks every year in hospitals. And like many EDS patients, we had to find specialists who understood the condition. So that required travel and that required, a lot of I joke you have to kiss a lot of toads, right? We would meet with doctors who we just kind of would overwhelm, and those appointments wouldn't go well. And there's no parenting book to explain to a child, why that doctor said to you, "I'm sorry, we don't treat EDS," or "I'm sorry, this is too complicated." So we just had to kind of live it and make it up as we go. And, the one thing, like I said, that unifies most people with EDS is they all have these long stories. So you can see my daughter's hip in the bottom right. She had 2 days of spinal surgery only to accidentally have her hip sublux. And, the hospital saying, well, it's not dislocated. There's nothing we can do. So we had to discharge her like that and go find our specialist to get her hip placed. Or my son, who had complex regional pain syndrome, which flares higher than amputation level pain. And, we have these wonderful pain programs that really try to help kids living with complex pain. But historically, they did not understand Ehlers-Danlos syndrome. And a lot of harm was done because they didn't realize that children like my son just needed a different approach to rehab. It had to be gentler, it had to be biomechanically focused. And so that's something that also has become a source of trauma that people don't really like to talk about, but is very alive and well within the population. And, there's proof. I mean, can you think of any other condition that medical papers are being actually written about, all of the high prevalence of misdiagnosis and the challenges? And this is not a problem that just affects patients. And that's why ElevateRARE was founded really as a support system for clinicians. I think we have the potential to be risk management's best friend because a lot of these adverse events with Ehlers-Danlos in many cases are predictable. And I think there's really great opportunity to not only improve patient safety, but also to improve clinician support because we know that our healthcare system is broken. We know our clinicians are way overworked, and we know that they need more support, not only within the medical community, but even sometimes within their own institutions. So again, both are impacted, and it hasn't been great, and it's getting better, but we still have a really long way to go. So why, and I'm going to kind of wrap this up because I really want to get to our speakers, but I just want to really impart on you why people with Ehlers-Danlos, do run into these problems getting care. Why do we create sometimes headaches for our physicians? And it really has to do with several factors. The first is it's a multi-system disorder. And again, they're just starting to understand more about the role of the immune system and the biomechanics. And this is all starting to come together in research, which is amazing. But there's that huge gap between what research knows and what's available in clinical practice. And that is unfortunately the margin of medicine that most EDS people find themselves. So when I say to you it's a multi-system disorder and it can affect all these systems, that means one thing to a doctor, but to a patient, that means I need to go find specialists on my own for every single one of these conditions because there is no centralized care. Not only do I have to find my own specialist, but I have to really hope that those specialists have knowledge of Ehlers-Danlos. They haven't just heard of it. And they really can know how to treat me. And again, it hasn't been taught in medical school to the degree that it needs to be. So this is, again, nobody's fault. But there is a huge room for improvement, and improvement really needs to happen. So for a patient, this just means I'm going to find my specialist. I might have to travel for care. I might have to pay out of pocket. And there's a really good chance that I have to coordinate communication because if these these physicians are not in the same hospital system or can't access the portal, all of the communication to coordinate my care comes down on me. Not to, belabor the point, but, people with Ehlers-Danlos syndrome are dealing with a condition of low awareness, lack of care, and high misinformation. And I do want to impart that the misinformation part, is becoming a little more concerning in the age of AI. We've kind of gone overnight from being the condition that people didn't really know about and really talk about to suddenly the condition that is so much talked about on TikTok and on social media, that people are actually calling it an overdiagnosed social media disease, which at least gives me a little bit of pause, because at least it means they know what Ehlers-Danlos is and we don't have to spell it anymore. But, again, to go back to Kathleen's point, it's not an easy road, 10 to 22 years for an accurate diagnosis. I can't tell you enough what misdiagnosis does to a patient, because you start going down one track and then you find out that, that care was not what you needed. Misdiagnosis also includes a high prevalence of psychological labeling. And, we will be doing a whole webinar on that, because unfortunately, once a patient is labeled, and people see that in the chart, with like conversion disorder, for example, a study by Dr. Chopra came out 67% of the patients surveyed had been diagnosed with conversion disorder. What that does is it destroys medical credibility. Objectivity. It destroys the objectivity. So when you present, the doctor might not take into account that you have something like POTS, which is my next slide, actually, dysautonomia, which has symptoms that can mimic anxiety and can make you physically feel anxious. But there might be the tendency to diagnose you with, conversion or a psychological disorder. And unfortunately, that is kind of a common thread in our film. That's something that happened to a lot of these kids very early on in their journey, and it absolutely hampered their ability to get medically objective care. So again, what does this mean for the patient? The high prevalence of misdiagnosis, it just means, as you see on the right, care can get delayed, wasted time, wasted money, wasted resources, disabilities can go on and on. It's not uncommon for patients to take breaks and retreat from care, which is actually something I recommend when they can, because the tendency to get very over-medicalized, because you do have to, unfortunately, sometimes kiss a lot of toads before you find your right specialist. It's just very detrimental. And that's what really leads to this trauma and secondary, PTSD in medical settings. So, basically, there's a lot of added burden on medically complex people, people with rare diseases, people who are undiagnosed, and people with Ehlers-Danlos syndrome. If you look at the financial burden, when we come into your office, $21,000 a year was a recent report looking at what the financial burden is. Well, what does that do to the family? Have you ever thought about the family dynamics and the stress that places on the family? There is no medical home. I do a lot of work with people that are newly diagnosed, and they're like, what do you mean I can't just go to the center? Now, don't get me wrong. We have two that are starting, UVA and MUSC, but even they are still ramping up to try to be able to provide complete care. And, there's just so much added burden. One thing that's always struck me about this condition is, unfortunately, where you live, if you can travel, how much money you have, how well you can articulate yourself in medical settings are all factors that sometimes can determine your ability to get effective care. That right there is a problem. So I just wanted to kind of explain that all these factors, unfortunately, do create a burden on patients and might impact how we show up. So when Ehlers-Danlos patients come in and they look anxious or untrusting, hypervigilant, frustrated, stressed, maybe even non-compliant. Non-compliant is my favorite, because you don't know what other specialists might be telling them. And that comes up a lot of times in our cases within child protection. But basically, this is how we show up. And I just want to challenge everyone out there, when you see Ehlers-Danlos patients, there is a lot of institutional bias against this condition that really is, again, not rooted in anything nefarious. It's just that there wasn't the education, there wasn't the research, there wasn't the clear diagnostic criteria. There's not well-established care pathways, and there's not well-established standards of care. So because of all that, we are under stress. We are going to show up. And the last piece I should mention is we do also have a very high percentage of neurodivergence in our community, something that is still being studied and not well understood, but it also might impact how we appear. So I just want to, say to everyone, when these patients come in, and you hear stories, especially within the hospital, oh, EDS people, they're all crazy. Or, in the case what we've heard, oh, we don't treat them, we don't treat Ehlers-Danlos. Think again, are these people these things, or is it really trauma? So until we're able to actually get what patients need, which is earlier recognition and diagnosis and coordinated care, and the comprehensive diagnostic criteria is hopefully coming at the end of the year with the new criteria being released. Until we get all these things that we need, what we really need in the meantime is actual trauma-informed care. And so that is the reason that we are having this. And I'm excited to turn this over now to Mary Jenner, who is going to tell us a little bit more about what that looks like. So Mary Jenna is the founder of the Innovative Care Institute, and which is dedicated to eliminating preventable medical trauma. And I love that you put it that way because a lot of this is preventable. She's also the founder of the Butterfly Pig, which is an amazing company that does medical toys to try to help ease the stress of kids when they're in medical settings, especially having procedures or in hospitals. She's also the podcast host of Care Rewritten, and she's focused again on trying to help end medical trauma in healthcare. So with that said, I'm going to hand this over to Mary.
Thank you. Let me get my screen up to share. Let's see. Can you all see this? All right. Can you see everything? Give me a thumbs up if you can. Okay, perfect. Realize I don't know if I can hear. So yes, my name is Mary Jenner. I'm a nurse turned healthcare innovator with a passion for reducing preventable healthcare-induced trauma for patients, families, and staff, because it really does affect everybody. I've unfortunately been the nurse at the bedside involved in distressing care. I've been the mom restraining my own two daughters during their own medical experiences. And I've been the patient in my adolescence. I had a lot of complex experiences in the healthcare system, was referred to all these different specialists, and it all seemed very unrelated. And I was even told, one of them saying, well, the mind is a powerful thing, because they didn't understand what was going on with me. And it wasn't until over a decade later, I finally saw a rheumatologist that got labs, and finally I had some proof that there is some autoimmune complexities going on. And so that experience has absolutely affected me and how I interact with the healthcare system. Even as a nurse, I put off saying stuff. I don't explain my whole medical history because I don't want to be seen as a hypochondriac. And it's all these experiences, it really adds in how we interact with the system around us. And so I expect for most of us here, this is quite personal. And I'm so honored to be here and glad that that ElevateRARE is putting on this, because we really need to bring more awareness to medical trauma. And the more we talk about it, the more you or others feel empowered to advocate for better for patients and caregivers, but also ultimately advocate and inspire change within our healthcare system. So let's talk medical trauma. It goes by many names. You may see there's medical traumatic stress, medical PTSD, CPTSD. Earlier, I talked about healthcare-induced trauma to try to wrap in the experiences of providers, but it's not really about the words that we are putting to it. It's more about the felt experience of medical care and what we take away from it consciously or even subconsciously. So there are tools and checklists to help diagnose it, like I have here on this slide. But those honestly exclude a lot of experiences and don't really give the full picture. So even though those are really helpful at looking at an experience retroactively, it also can really hinder the prevention aspect, because we don't want to wait until somebody has diagnosed PTSD to do something about it. We want to look at it from every aspect and be able to recognize when experiences can be traumatic so we can start preventing it too. So there are This slide is really just to give a picture of why trauma is such a personal thing. It is how we are raised, that nature versus nurture aspect of care. It's the support system around us, the medical system, whether or not you're getting care at like a trauma-informed institution or not, and environmental factors. So when we're talking about medical trauma, I've actually found that even when I've done presentations to nurses and I say the words trauma-informed, people have thought that I meant, are they educated in like subject or objective traumas, like working in an ER and there's car accidents and level 1 traumas come in. That's what is often programmed into a lot of healthcare providers' minds when they hear the word trauma, rather than the psychological aspect of trauma. But psychological, like the medical trauma, is actually more about your subjective experience. So it doesn't matter how objectively severe something is, it's just more what you take away from it. So that's why you can have painless procedures lead to lasting medical trauma, or how providers communicate with you, or even that medical gaslighting or being dismissed. All of that can lead to medical trauma. And really, it also, especially with medical complexities, that chronic and repeated loss of autonomy within the healthcare system can lead to it as well. So there are many different ways that medical trauma can manifest, and this is just scratching the surface. And again, it's incredibly unique. So not everyone is going to experience every symptom. Sometimes it's conscious and we're aware of it, like repeating memories of the situations or situation that was traumatic. Sometimes it's more subconscious. There's a thing called implicit memories, where just like when you walk into a place and you smell something and it reminds you of your grandmother's house, like that's an implicit memory. And that same thing can happen with trauma, with like walking into a hospital and familiar smells can trigger like your heart rate getting quicker and different bodily reactions. So once we can recognize that potentially we or our loved ones may have medical trauma, it really opens the door to healing and finding support, because now you can have words to put into it and start looking for those resources and support systems, and even advocating to prevent further trauma in the future. So if you know that there are certain triggers or things that bring up those symptoms and memories, then potentially we can have those conversations with our providers around prevention. Because frankly, medical trauma isn't talked about enough, and it's something that we should be addressing with our providers. So that brings us to CPTSD, because there's an official diagnosis for this. It's complex PTSD. And it's the symptoms of PTSD, as well as 3 additional factors. One of them is emotional regulation difficulties, like maybe feeling numb, or the opposite of being I know it's a negative term, but feeling like explosive is what like some clinicians might attach to it, just having overwhelming emotions. There's also the negative self-concept, so like feeling fundamentally changed from the trauma, and relationship difficulties, like feeling loss of trust or even feeling disconnected. But there's an interesting conversation happening right now within the medically complex community, because the nature of PTSD is it's post-traumatic stress. But with medical complexities, often you don't have that post period, it's continuous. So there is a QR code here because there's a medically complex mother who worked with the IRB to get this survey approved, to get more information and to try to study this more of what these experiences are like, really just to open the conversation more and bring this unique continuous stress conversation into play and research so we can learn more about it. And with trauma, it's a huge ripple. So kind of like we addressed, it's not just the patient themselves that experiences trauma. It can, if it's an adult, it can affect children. If there are children experiencing trauma, it can affect the parents. It affects siblings and hospital staff, and even hospital roommates that are witnessing and being involved in it. And it really just affects the entire health system. And we talk about with healthcare organizations about it's really likely costing them billions of dollars with medical trauma. It's just really hard to tie to a line item. So it's been very difficult to create change in this area. So parental stress is, of course, something that happens when your child is undergoing a traumatic or distressing medical experience. And unfortunately, it's seen that when parents are stressed, there's a strong correlation with poor outcomes for the child as well. One study even found that parental stress was the strongest predictor of child post-traumatic stress symptoms after pediatric hospitalization. So parent stress does influence what a child takes away from it too. So just like being instructed on a plane to put your own oxygen mask on first, we need to take care of our mental health and potential trauma as parents in order to be there for our children. So it is even, we might downplay our own trauma we're taking away from it when it's our child because we're like, no, it's nothing compared to what they're going through. But we really do need to seek out supports as parents in order to heal ourselves as well. So whether that's after the fact, finding support groups, or while we're there at hospitals requesting psychosocial support, that's all really important. And it affects siblings as well. It can be one event that was really objectively traumatic for a sibling, or it could be repeated exposures where siblings might feel fear or helplessness or loss of control when they're watching their sibling go through something. And I recently spoke to a mother of, she has multiple children, but one of them has an autoimmune condition that has required weekly injections at home for a decade. And she said that her younger daughter, witnessing these injections every week, she thought that her sister was being abused because the parents would hold down the older sibling while they'd give the injection every week. And it wasn't until she was old enough to have those words and express what was going on that they realized how it affected her. So now she's in therapy for it, and it's affected her own outlook on the medical system. And a study even showed that siblings of chronically ill children actually rated their quality of life impact higher than parents. So often we might not even realize how it's affecting them. So now having this knowledge too, this is where it's important to ask for support for siblings even in the hospital while you're there, because typically in the hospital is when you have access to most resources. So it would be asking for Child Life to come and speak with your sibling, or even if your daughter or son is on a local support waiver program, like my daughter's seen by the regional center here, they can often fund or help cover private child life specialists or other psychosocial supports too. And then it affects providers. And so being involved in and witnessing traumatic and distressing care leads to burnout and moral injury, compassion fatigue. And as you can see through this little diagram I made, when you're involved in distressing care, it doesn't feel good. Nobody wants to be doing it. So that's what leads to all these things. People end up leaving the bedside. It puts us back in survival mode where we're more at risk for providing more distressing care, which I'll get into in a moment. But it's just this loop because the system isn't really supporting families or clinicians in medical trauma. It just loops back and is unfortunately causing more trauma. And there was a study that actually looked at this where it was mainly nurses that they interviewed, where they recognized when they were part of distressing care, like restraint and holding kids down, when they were being interviewed, it was bringing up lots of emotion, and yet they kept talking about how they were doing it because it was in their best interest, in the child's best interest. So they coined it the transient empathic blindness, where professionals are basically suspending empathy in order to get the job done. It's not something they're consciously doing. It's just something that their brain is doing automatically when they're in survival mode. It's making a hierarchy of duties saying that you need to get this done before you even care about what they're taking emotionally or psychologically away from this. And that leads to this too. There was research back in the 80s that confirmed that brains have a max capacity or cognitive load. So when you see these medical staff on the unit, you have alarms beeping, call lights going off, there's assessment, vital intervals. It's a really overwhelming environment, even for patients. So when all this is happening and it is causing our brain to juggle too much, and we lose that working memory where like our trauma-informed training lives. So even if we are in the bedside and a child all of a sudden starts having resistance or distress with what's going on, then the actual provider there might not even be in the right mindset to realize that we can pause and call child life, or pause, take a breather, and wait a few minutes to calm down and or think of another path. So that is something that we're talking about here, because as a parent, it's really, we want you to just advocate and recognize that a lot of what is happening, it isn't something that is personal. It's not that providers don't care most of the time. It's not that they don't care. It's just that the brain is working in this stressed environment. So when you're at the bedside, like we want you to advocate. And I'm guilty of people pleasing and staying silent when I'm the patient or the parent in healthcare, because I've absolutely put off speaking up and saying something because I don't want to make this stranger or the nurse uncomfortable. But that's now putting that stranger's healthcare or psychological needs before my own or my child's. But when I'm the nurse at the bedside, like, I want you talking and advocating, because we all know that you know your child best and you know yourself best. And sometimes it feels like a fight, but like we need to be okay with looking like we're overbearing or whatever, because that is it's you know yourself and your child best. So that being said, we need to have conversations more with providers. So even when you're in the hospital or at the doctor's office and they're ordering tests, like it sometimes, even though it shouldn't feel like it's up to us, it really is parents. We need to be able to say, okay, how can we make this less traumatic? And sometimes that's all it takes for the doctor to realize, oh, right, like, let me get child life on board, or, oh, we can practice doing it this way. So there are different techniques that are less traumatic and resources out there. So we're going to share, after this, ElevateRARE will share a document with resources in there as well. But this top QR code is a Facebook group that we have, where we've created a safe space where people can come in and share about experiences and either ideate solutions around it, or even there's a lot of really people that have a lot of lived experience in there, so they might know of resources to help. And then there's also a company that does virtual child life appointments. So I know not every healthcare system has it. So this is a way to increase access to child life. So it's for preparing for children to have procedures, or if there already is trauma or even sibling support, they help with all of that. So yeah, thank you all for being here. That's the end of my presentation.
Great. Thank you so much, Mary. That was amazing. Absolutely amazing. And thank you for the resources. Yes, we are going to have a Q&A at the end of this where people can ask specific questions of specific people. And we will definitely be putting up the list of resources that were mentioned. Vanessa, as I had shared before, is a speech language pathologist. She has her own lived experience, like many, that has led her to her passion and doing the work that she does as a founder of New Healing, working on treatments of the disorder system. And as we know, a lot of people with Ehlers-Danlos, the nervous system is very central to a lot of the challenges and symptoms that we have. She's also the author of Speechless: How a Speech Therapist Lost Her Ability to Speak and Her Silent Struggle to Reclaim Her Voice in Life after some very harrowing experiences in ICU. So her work in PICS, which is not very often talked about, and that's why ElevateRARE wants to start elevating this kind of stuff, is really insightful. So Vanessa, I will let you take it away, and I'm going to try to figure out how to make this slide a little bit bigger, but take it away.
All right. Thank you. So thank you, everybody, for being here. As Donna said, I am an ICU survivor and speech pathologist. I learned what it was like to be the patient in the bed about 6 years ago. Just a little bit of background on me. As I said, or actually it was 7 years ago, I'm sorry. I had the diagnosis of Guillain-Barré, and my variant is called the PCB variant. So it stands for pharyngeal cervical brachial variant of Guillain-Barré. So PCB, GBS. And like what you guys experience with EDS, I too live with a very rare disease. They say GBS is a rare disease. I don't know if it's so much rare anymore. It feels like more and more people are getting this. Maybe people are just talking about it more. But my variant, the PCB, is extremely rare, to the point that often neurologists have come to me and said, wow, Vanessa, you're really lucky you got a diagnosis, because I've never heard of this before. I also wanted to say too, 7 years ago when I got diagnosed, I reached out onto Facebook, made a Facebook page for the PCB GBS variant, hoping to connect with people in the community that had this, so I could connect with them, talk with them. And to this day, 7 years later, I don't have a single follower in that group. It's been that hard for me to find community. I've reached out to the GBS corporate offices, and emails go unresponded to. Nobody knows anything about this. So I feel like I'm like the one out there alone. So I lost my voice with my variant. I lost my ability to swallow. I lost my ability to move. I was on a ventilator. I use eye gaze technology to communicate. As a speech pathologist, it's pretty wild to have experienced. I use text to speech. I even use the alphabet board. I live with post-intensive care syndrome, PICS, and that's what I'm going to talk about with you today. This is what happens after the ICU, especially for those of you in the rare disease community who already knows, you guys know what it means to fight to be believed. So we can go into the next slide. We're going to talk about PICS and post-intensive care syndrome. So this refers to new or worsening problems in physical, cognitive, or mental health that begin during or after a critical illness and persist beyond that acute hospital stay. So again, there's those 3 points. There's the physical, which we're talking about the weakness, the fatigue, the swallowing problems, the voice problems, the chronic pain that it can experience. These can persist months, years, or a lifetime. The cognitive domain, so we're talking about memory loss, brain fog, difficulties concentrating, word finding problems. ICU survivors often describe feeling like a different person. And that was me. I just kept trying to tell people, like, I just don't feel like me. The psychological, you're dealing with the PTSD, the depression, anxiety, the loss of identity. Research shows that ICU-related post-traumatic stress can be as severe as combat PTSD, but we don't receive that same service or attention, which is just really sad. I want to ask you guys too, have you guys heard of PICS, post-intensive care syndrome? Just kind of curious if anybody has heard this term before. If you want to just type in the chat real quick. Good. Yes. No. Never heard of it. Well, I love being here today to have these conversations with the people that have not heard it. In addition to the people that have heard it, maybe you'll learn something new today. But it's real. It's definitely real, and it's something that we need to be talking about. All right, you want to change to the next slide, please? All right, the scope, go back one. There you go. Scope of PICS. I want these numbers to land with you for a minute, okay? 5 million Americans survive critical illness every year. That's not small. That's like a stadium size over and over and over again. 80% of ICU survivors experience PICS. That's not rare either. This is the norm, 80% after a critical illness. That's huge. 50% develop post-traumatic stress or depression. That's half. And no one's screened for it, no one's talking about it. 2 years on average before PICS is it recognized or even named for survivors. I'm lucky I got diagnosed pretty early on, but to wait 2 years for anybody to make those connections, that's just, it's horrible. It means that there's a lot of people walking around on the streets suffering, looking for answers, and they're being dismissed. All right, you want to head to the next slide? All right. Why EDS patients are specifically vulnerable. I want to spend some real time here because this is the intersection that rarely gets discussed. So pre-existing medical trauma. Many EDS patients have already experienced years of being dismissed, misdiagnosed, gaslit before even reaching the ICU. The trauma tank is already overflowing. A critical illness doesn't just start from zero, right? It adds to a body and a nervous system already carrying a very, very heavy load. Complex medical presentation. So EDS affects connective tissue throughout the body, fragile musculature, dysautonomia, MCAS. These complicate ICU care in ways that many critical teams are not even trained for. We know that. Procedures that are routine for other patients carry higher risk. Heightened nervous system sensitivity, so hypermobility, autonomic dysfunction. I mean, the body's stress response is already very dysregulated, right? PTSD symptoms post-ICU can be more intense, harder to treat, and more easily triggered. The gaslighting and non-belief, this one's huge. When patients have been told their symptoms aren't real, when they've been internalized that message, they often don't report symptoms after discharge. So they're not talking about their PICS. They assume they won't be believed again. And therefore, they suffer in silence. And that's just heartbreaking. Loss of hard-won baseline. So EDS patients work incredibly hard to maintain their level of function. An ICU stay can erase years of physical therapy, pain management strategies, careful routines. That loss is compounded. It's not just the ICU. It is everything that came before it for patients. And the last one is lack of community crossover. So PICS resources are rarely discussed, period. It's just not, nobody knows about it. Then you combine that with a rare disease where clinicians already don't know how to respond, right? And this causes patients to fall through the cracks and not receive the supports that they really need. All right, you want to go to the next one? All right, PICS family. When a patient enters the ICU, the entire family enters that trauma. PICS family is a recognized parallel syndrome, but it is almost never addressed in clinical care and almost never discussed in survivor communities either. They just kind of tend to forget about the caregivers. Families watched their loved ones on a ventilator. They made life or death decisions. They were never prepared for this. They go home exhausted and terrified every night. That was my husband. He would go home just shell-shocked, like, what do I do? And when the patient comes home, the family often becomes the primary caregiver. They lose their identity. They don't have any training. There's no support for them, no time to prepare, and no recognition of the trauma that they endured either. For EDS families specifically, they were already in caregiver mode, right? Many have watched their loved ones fight for years to be believed by medicine. The fear that the ICU team doesn't fully understand their loved one's complexity is often warranted. And that's hypervigilance is exhausting for the family members. So what do families need? What do they need most? They need to be told what they experienced is real, that there's a name for it, and that they deserve support too. Family members need to be educated on what their loved one experienced and that they may not be the same when they come home. So patient education is just huge, patient and family education. But again, nobody knows PICS. There's not a name for it. All right, you can go to the next slide, please. So what does PICS look like in the rare disease patient? And there are 4 clinical realities I want you to take home from this slide. The first one, I was already disabled. One of the most challenging aspects of PICS in rare disease patients is attribution. So when a patient or provider sees someone with EDS who is fatigued or weak or cognitively slower post-ICU, it's easy for them to say, oh, that's just the EDS. New PICS symptoms gets collapsed into pre-existing diagnosis and it goes untreated. Another one, no one knew my baseline. Well, ICU teams meeting a rare disease patient in crisis rarely have any context for what that patient's normal looks like. So without a baseline, progress is invisible and decline often goes undetected. Another one that's common, I can't go back to the hospital. That was so me. PICS-related medical avoidance is well documented and very common. And for rare disease patients who already had traumatic medical experiences, this avoidance can be so dangerous. They often delay care. They don't want to go back. They stop advocating for themselves. And they completely disappear from the system. And that is so dangerous. The other one, I'm grieving something that no one else can see. This is the grief of lost function, lost capacity, lost quality of life. No one around you can validate that for you. It's real, it's very significant, and it deserves a name. All right, you can go to the next one, please. So I want you to go home with some things that you can do. I want to leave you with some actions, not just an awareness of PICS. So for patients and families, start by knowing what you've experienced does have a name, PICS. You're not imagining it. So I want you to ask your provider too, have you screened me for PICS? Many even haven't even considered it because they don't even know it exists. You can also seek an interdisciplinary team. One specialist cannot treat PICS alone. That's just evidence-based. You need an SLP for communication, cognition, voice and swallowing. You need PT for physical recovery. You need psychology for the post-traumatic stress and the depression, anxiety, and often a primary care provider who understands the whole picture of what you've been through. Find your people. That's another one that's so important. ICU survivor peer communities are irreplaceable, and I'll get into that in a bit. No clinician can replicate what another survivor can offer you. I believe for me, my peer support group saved my life outside of the ICU. They are now some of my closest friends. Although we've never met in person, we all meet virtually, but they understand me. And I'll provide a list of resources and further slides where you can learn and get some support around the world, all virtually. And things that providers and advocates can do. You first and foremost, believe the patient. Always start there. Believe the patient. Use trauma-informed language when talking to them. Screen the families too for PICS. They need supports. Advocate for post-ICU follow-up clinics. There's not very many of them. They're growing, but the more we have these conversations, the more it'll get out there. These ICU follow-up clinics truly save lives, and they're just so rare. All right, you can go to the next slide, please. I absolutely love this slide, and whenever I speak, I put this on here because the first time I saw it, it was jaw-dropping, and I thought, okay, what I'm experiencing is normal. This is the data behind what survivors describe as not feeling like myself anymore, and that was me. Like, what's wrong with me? I survived. I should be grateful. I should this. And why am I feeling this way? What is going on? The Brain ICU study published by the New England Journal of Medicine in 2014 followed ICU survivors across 4 cognitive domains at 3 months and 12 months post-discharge. And I know this slide is kind of small, it's difficult to see, but on the far left side, part A is for patients under 65, and on the far right, the 2 rectangles on that side are patients over the age of 65. And what this says is basically, I'm going to summarize the chart. Every age group scored below the normal cognitive range at 3 months. So if you can see on the very top, the green dotted line, that's normal cognitive functioning, okay? The little line below that, it's kind of like, it's kind of orange colored. It's mild cognitive impairment. The line below that is traumatic brain injury. And the very bottom line, it's kind of pinkish colored, is Alzheimer's disease. So again, every age group scored below normal cognitive range at 3 months. Not some patients, this is all of them across all 4 domains: global cognition, immediate memory, delayed memory, and attention. Now for patients over 65, scores at 3 months fell at or below the range typically associated with Alzheimer's disease. That is significant. At 12 months, scores improved in both domains there, but still remain below normal limits. This is not a short-term problem. This is a long-term neurological impairment following a critical illness. And for EDS patients who already experience cognitive symptoms, dysautonomia-related brain fog, medication effects, pain, this compounds an already very complex picture. All right, next slide, please. And of course, as a speech pathologist, I have to talk about communication. This slide is very personal to me, and I lived this same cycle as a patient in the ICU. There's 4 forces interact to create a cycle of silence in the ICU. So there's sedation, anxiety and agitation, the physical inability to communicate, and altered cognition, and weakness. So here's the cruel irony of this circle. When patients cannot communicate, anxiety increases. When anxiety increases, providers often increase the sedation. More sedation means less ability to communicate. And the cycle just keeps feeding itself over and over again. So again, I was on a ventilator. I could not speak. I could not swallow. I used eye gaze technology. Eventually, I was able to use text to speech. I had my phone. Eventually used a PMV, a passing mirror valve. All of these I was given because someone thought to bring it to me, but not every patient has that. And again, this comes down to providers recognizing that patients need a form of communication, whether it's just eye gaze and blinking or pointing to yes and no. It is so important. And for EDS patients who already struggle to be believed, who have spent years carefully crafting the words to describe their symptoms to providers that don't believe them, losing the ability to communicate in the ICU is not just frightening, it's terribly, terribly dangerous. So this is why AAC, Augmentative Alternative Communication, is why I talk about this. It belongs in every ICU, even low tech, like I was saying, blinking, squeezing a hand, pointing to yes, no, pointing to pain, pointing to water, whatever it is. It's why SLPs belong at the bedside from day one of admission, not just for swallowing or cognitive screens, but to get patients a means of communication. And it doesn't have to be an iPad. Like there's iPads that are high tech and can formulate long paragraph sentence of utterances. Yes, no, hot, cold, water, no water, pain, rotate me, flip me, uncomfortable, just one word. So important. All right, next slide, please. All right, and in conclusion, I said before I wanted to leave you with resources and support. These are a starting point. I especially want to highlight the SCCM PICS support community, that stands for Society of Critical Care Medicine, the Vanderbilt support group, and the UPMC Mercy ICU PICS support group. Peer connection is one of the most powerful tools in PICS recovery. I'm telling you, like I said in the previous slides, I think they're the reason I'm still here today. The Medical Trauma Support website also offers a peer support group that meets virtually, and she also has a podcast relating to medical trauma. It's been very helpful to survivors not to feel so alone. Personally, I've been a part of all of these mentioned groups, and when I was in the darkest places in my life, it was through these support groups that I was able to find community, and when I found that community, I found hope again. So for rare disease-specific sport, NORD, NORD, and the Ehlers-Danlos Society both have provider directories and community resources. Another one that's not mentioned on this site that I really love and I'm heavily involved in right now is WALK, the number 4, PICS, PICS.com. If you go to that website, you can establish your own WALK for PICS, and we're doing that in September, and you can get on the list on that website, and it gives you a whole bunch of medical trauma aware therapists. So yeah, if there's anything you guys need help with or family members, those are all very, very good resources. So I want to thank you for your time. I appreciate for you attending today, and I hope you were able to learn that what you or loved ones are experiencing is indeed real, and it has a name, and it's called PICS. So thank you again.
Hi, everybody. Thank you so much for that, Vanessa. That was really a tremendous presentation and really kind of hit close to home in terms of, common experiences. And I'm sure a lot of people that are on this call have. So Danielle is someone that I recently met at a conference. She is an incredible patient advocate. And she's a patient herself, and she is a healing practitioner. She uses a lot of different modalities. And we thought it might be really interesting to not only kind of set the stage for what is the EDS patient experience, and then bring in 2 experts to talk about kind of the clinician's perspective, but we really wanted to kind of end the session with Danielle. So if Vanessa does come back and join us, we will have Vanessa present afterwards, and we'll absolutely make her slides available. But let's just kind of switch the order here. And wait a minute, Mary's back in. That's weird. And then We'll go to Danielle. So Danielle is basically a wellness ambassador as she employs holistic care in her own healthcare. She's an ally to individuals who are living with medical and workplace trauma. She has over a decade of experience, and she serves on the patient advisory board at University of Virginia's newly opened EDS Hypermobility and Disorder Center. So Danielle, take it away.
Thank you. Thanks for having me. My name is Danielle. I am a patient, as mentioned. I'm here to share a bit of my experience with medical trauma, navigating chronic illness, acute injury, workplace trauma in the mix. And I only mention that because it came as a result of my health condition. I am still tending to, mental and emotional wounds. As Mary said, it's kind of a continuous process being a patient. It's not really a post period. The ripple can be real. So some wounds are obviously fresher than others, but some of the practices that I'll talk about later have helped me through. I definitely have a full-time job healing, full-time job as a patient, but my efforts do revolve around being human as well. And part of my human healing work is bringing awareness to this overlap of some of the patterns that I've noticed, both in the medical industry and just in workplace complications when you are a complicated patient. You can go to the next slide if you'd like. Thank you for directing. Just a few disclaimers, not giving medical advice. I am just sharing from lived experience. I'm a bendy patient, got a bendy brain, got that neurodivergent overlap. So, I relate to a lot of both the physical and mental aspects of trauma and how it shows up. I do have an educational background in mind-body transformational psychology, clinical aromatherapy, and reflexology as well. I've relied on an integrative approach myself, both Eastern, Western realms. They're both important in my world. I do value emergency medicine, radiology, things like that. But, after the diagnostics and things that I need, I basically treat in the Eastern realm. So traditional Chinese medicine, like acupuncture, Ayurveda, the science of life. It's gotten a lot of progress in those bigger areas. These disabilities are dynamic, so things look kind of different every day. As I mentioned, management is kind of a full-time job. And my advocacy skills have been sharpened naturally, both with my own experience and then being part of the community, helping others kind of navigate their hoops and loops have also, been part of my repertoire of skills. We are whole and wholly humans, right? So billing codes and traumas aside, I think tending to basic essential needs here is huge. And, support, security, things like that go a long way. And I also want to acknowledge my privilege here. I've had varying access to care, both in really, really good arenas and also not. So I think that spectrum has given me a lot of insight to kind of comment on some of the more systemic things that I've discovered. Go ahead and go next. I'm doing it all for that little innocent girl on the left there. A lot of my inner work, I had to break stigmas and kind of travel back in time to when I was a child, when I was an adolescent, taking a raw, honest inventory of things that left a mark without further suppression or gaslighting myself or repression in that sense. My younger years were pretty challenging. I was and still am heavily judged by how I look, my weight, which turned out to be a medical thing. The hypochondriac terms, always had issues or something going on or careful enough or whatever. It's like the blame and the shame got so much louder than my own internal innate knowledge. And so I think I adopted some of that narrative internally, and a lot of my healing has been unhearing a lot of that and unlearning a lot of that. Aside from, mental impact, there was some physical impact from one of my times in a treatment facility from another patient. It's not always provider caused harm or system caused harm. So unfortunately, that left a mark. Kids are very cruel when they find out you're different or have been to the hospital a bunch. You get picked on, and there's a lot of grief and loss. And that social aspect becomes really challenging on top of the condition. There's a lot of grief and loss and addiction and close calls that I've had to endure, some isolation, plenty of isolation, I should say, and, some unhealthy behaviors that moved into adulthood as a result. A lot of the things were symptoms that I had to get to the root cause of. So I did gravitate towards healing arts school because of my own ailments and experiences and interest. I seemed to then become inadvertently my own case study because I had a pretty gnarly back injury, and my surgery post school was kind of my metamorphosis. And I first learned about my bigger calling to be an advocate at that point because a lot of the harm came from post-operative care in that surgery. Something called healthcare associated infections developed for me in the rehabilitation center, and I had to have a pretty crazy return to the ER after that surgery, and that I'm still dealing with ripples of that 7 years ago. It's something that I even had an appointment this week from a spine doctor telling me something about this surgery was not holding, so it's just, it goes on, and it's something that you just kind of have to accept and adapt to and move with and find purpose in somehow, even on some of the days that seem a little hopeless and crazy. But I could even feel my body in this appointment this week kind of tighten up, and I got, some of those physical symptoms when I heard this provider mention surgery, right? So it's still there, and it's still things that I have to then use my tools to navigate during that appointment. I won't go into a whole more, bits of the trauma. You can go to the next slide. We've all seen that it comes in different shapes and sizes. I put a resource here that can get sent out as well, where there's, more attention being brought to the clinician-associated traumatization, specifically in the EDS community. So you guys can do a little bit more enlightening of yourselves with that newly published article. You can go to the next slide. In interest of time, I want to get to some of the good stuff. With some of my experiences, I've had to do a lot of alchemy work, finding out that my termination from my corporate career due to my health issues, that ended up being my liberation. The struggles end up bringing a lot of awareness to bigger problems. I wasn't, once I started to realize I wasn't the only one going through some of these things, and it was a systemic, structural issue, it kind of pivoted my energy and work in this kind of field where we have to be looking at some of the unstableness of our framework, our essential needs not being met, how we're, even in today's world, cutting funding for a lot of these services that can really help people when they need somewhere to fall. The gaslighting that we've talked about, the disbelief, the dismissal, that leaves such a lasting impact to where sometimes that will impact the internal narrative that patients have, so that sometimes I don't even believe what's going on because someone's told me so many other things, so many different ways. The delay in diagnosis, also over and under diagnosis. I've battled all of those things, and it's exhausting. It's confusing. It wastes resources, time, energy. And like I said in the beginning, I just wanted to get back to being human, whatever that meant. Privilege and access to care. We're navigating a for-profit industry here. I think that doesn't get addressed loud enough. We all know it, but I think that we're not talking about it enough. And I think the complicated patients that end up getting fired for being too complex, that just creates the process all over again. And that burnout cycle that we talked about is just further exacerbation of the symptoms. So in getting to the healing aspect of everything, I want to share some of my modalities that I personally lean on. Plenty of other options out there. And if anyone has any questions or, wants elaboration, please contact me after this. Aromatherapy has been a huge one for me. I know there can be sensitivities in people's immune systems, mast cell, things like that. But it really is helpful for the mental and emotional navigations that come with I've got one right here just in case I got a little nervous today, or, going into an appointment, it helps ground me and make sure that I can relay all of the things that I need to say to the doctor in the very short time that I have. body work, not just massage, but like in the body work, somatic work, tapping, helping with my proprioception. I have a lot of tools around the house that I work on myself. So that's been really helpful when I can't always get to clinic. As far as mental health goes, I found a lot of relief in the internal family systems model that I've worked with my therapist on. I've also gone through transcranial magnetic stimulation, which is really great in helping create new neural pathways, especially when I've not wanted to do necessarily like medication treatment. Movement and meditation and nutrition, all these things I consider modalities as well. They're not just habits or lifestyle things. They are actually tools that I rely on every day to make sure that my health is in order, not just, for fun or whatever the case may be. And then my favorite type of work, as far as clinical work goes, is my osteopath. Neuromuscular skeletal medicine is very helpful. It's not very aggressive like chiropractic. Subtle adjustments really help. It tends to the nervous system. Acupuncture, same thing. I do both for physical ailments as well as mental and emotional health. Vagus nerve, nervous system work is incredibly helpful in the trauma realm. You can go ahead and go to the next slide. And then some of the other things that I had to start looking at that were missing in my life because illness took up so much time. I was not being creative. I was not in community. I was not traveling like I loved. I was, losing a lot of these things, and processing the grief is one thing, but then finding a way forward is another. So, I always talk about my library classes because I've gotten so much out of that. Just signing up for a free class, I can go be with people that I don't have to maintain relationship with. It's like an easy, low spoon sort of familiar face, but no required like further follow up after that. I can do art class with supplies there. It gets me out of the house. There were a lot of days where I could not get out of the house. And, we like to think smart, and I want to try to feed five birds with one scone instead of killing two birds with one, right? So whatever I can do in that activity that checks off a lot of these boxes in one is a prime activity for me. Time management, pacing, adding buffers to things, giving myself that cognitive rest, not just physical rest. Case management for my own care is a hefty order. So making sure that I actually schedule in like simple pleasures on the backside of an appointment, or, just something to bring a little bit of joy or sprinkle some ease into my day. And then, getting back into the natural world, both relying on plant allies and plant medicine in my healing, but using the elements to help, ground and center and combat some of the crazy chaos that we have to endure in the system. And then being of service. I wasn't working for a long time, and I don't know what my capacity is to return to a career. I'm still healing from that, but giving back and being able to speak and share experience and leave a ripple in somebody else's life has also been a huge part of my own healing. You can go to the next slide. I have a lot going on in my brain, and so mantras have been a huge piece of my recovery as well. I think as bendy people, we often have proprioception issues, like where's my body in space, right? But I always have to really check in with my breath. Is it up here in my chest? Am I really nervous? Am I giving myself that deeper breathing, that diaphragmatic breathing, to give myself both ease in my body, but then to present what I need to present to providers, or, say what I need to say in a webinar like this. I mean, I practice these things on a daily basis, and they have to be easy to remember for me to be able to do it. Life definitely had a way of slowing me down when I was going too fast. And so I always say now, like, the fastest way to get there is to go slow. My dad was a football player, and he used to always say, inch by inch is a cinch, yard by yard is hard. And so thought it was like the corniest thing ever, but has it not turned out to be the most true thing in my life? Doing less to be more, right? Like, we're doing a lot of things all the time, and just being is also part of our structure. And so carving out time for presence has been important. There's a lot of power in that pause, like Mary was saying too. Like if we just take a moment, take a breath, both as patients and as providers before we're walking into an appointment, like let's not think about the last XYZ thing. Like let's take a moment and be very present and centered with our patients. That's how we're all going to be on the same team. It's not patients and providers against each other. It needs to be all of us bucking the system a little bit. And so I think all of these practices go hand in hand. And we may all be zebras, but I always say we have different stripes, strategies, superpowers, stories. So you really have to carve out and find what works for you. And that comes with autonomy over automation for me. Like I wasn't trying to memorize protocols and, doing all these things that were creating a lot of busy. I wanted to quiet it all down, tune into my innate knowledge, my innate wisdom, my intuition, and move from that space mindfully every day. Gratitude is a huge practice, and I want to thank all of you for being here. Thank everyone for having me to talk about all of this. I know sometimes gratitude practices can sound a little cheesy, but it has become a big staple in my life, and it helps keep my privilege in check. It helps just make some of these really hard, challenging things feel a little bit less heavy. And there's always something I can come back to being grateful for in any given moment. And that takes me out of my struggle and out of my story just for a split second. And yeah, if anybody wants to connect, here's my email. I have my Instagram coded there. I don't have a whole lot of social presence on purpose, but if anybody would like to get any more information or reach out, I'm always open to connecting and chatting and going from there. So thanks again, everyone, for having me. We'll sign off.
There's a lot of resources, patient groups, nonprofits, organizations that are having these kinds of conversations with support. And our hope is that presentations like this, if we can start bringing in and bridging the gap with more practitioners and institutions, we can try to start raising more awareness of conditions like PICS and some of the other topics that we talked about in terms of complex PTSD. If anybody has any questions or wants to ask anything of our panelists, I would say put your question in the chat. If there's someone specific that you want to talk to, let us know. So I'll open up the chat for questions. And I also want to thank again the Connective Tissue Coalition and Chronic Pain Partners for sponsoring this event, and just all of you for supporting ElevateRARE, our new endeavor. So the first question is from Chris, and it has to do, I'm not sure who this is directed at. It says, what broad panel genetic test would you order if it comes back with no definitive findings, only variants of uncertain significance? How do you counsel patients? All right, so Chris, that's a really big question in Ehlers-Danlos and in many rare and complex conditions. And I always think to myself, they say, oh, it's a variant of unknown significance, so it doesn't mean anything. And it's like, well, what if it does? Because I have all these symptoms. Unfortunately, you're really at the mercy of the geneticist that you work with. And I can tell you that all geneticists, like physicians, are not all created equal. So sometimes if you're having a panel and you're having continued symptoms and nobody's kind of getting to the bottom of it, it can be useful to reach into these nonprofits or these groups, or even, folks like us at ElevateRARE, who kind of know who some of these geneticists are, who are really working on the really complex stuff. So that's what I would recommend, because as you know, unknown significance just means they don't know what it is. It doesn't necessarily mean it's not pathological, and don't let anyone tell you that it is. The next question, any concerns about AI use in medical settings, lack of privacy, error, hallucinations? I don't know if anyone else wants to answer that. I will tell you, for me, that's a huge concern. The ability, there's so much misinformation out there right now. There's so much even published medical information that now we're learning was not quite accurate. So yes, it's definitely a concern. And I think if anything else, it kind of heightens the need to really try to build your own strong medical team and try to build a team that you can rely on and depend on to help you kind of navigate the information. I think clinically AI can help clinicians a lot. I don't know if anyone else wants to comment. Raise your hand, I guess, Mary or Vanessa or anyone else talk about it in clinical settings. But yeah, Danielle, I see that. Okay, Danielle, you want to respond? Can you unmute Danielle?
Yeah, I can chime in on this one. Coming from my career in big tech, I'm very opposed to a lot of the direction that it's going and the swiftness in which it's happening. There's a lot of errors that are happening. I personally can speak to like one of my medical claims being denied by the computer, and it was claiming that I was a 63-year-old woman requesting a power lift seat when it was just me, 39-year-old at the time, asking for compression devices. And that error followed through all the way to me having to go to a state fair hearing to beg a judge and a doctor I didn't know for these devices. And in the court documents, I was still 63 and I still got denied. That's one of 1,001 examples I could probably even personally tell you. So I won't take up all the time, but I definitely have concerns and reservations about cutting corners, about there not being quality control, checking for these errors, and just the lack of human input. The fact that a human couldn't fix this problem that I had, and I had to spend 6 months and end up in court over it, right? So, yeah, plenty of concerns. If anyone wants to reach out, I can talk about that more.
Perfect. Thank you. It looks like we're at the end of our time here, but once again, I want to thank everybody for coming. I want to thank our presenters for sharing, all this great information and their work with us. We will make all of this information available on the website, and I invite everyone to follow us on social media. Sign up for our newsletter if you haven't done so already. And, let's keep having more of these kind of uncomfortable but really important conversations, because that's really the only way we're going to move the needle forward. So if you haven't seen the film Complicated, check it out, book a screening, and you know where to reach us. And again, thank you to everybody. I hope you have a great day.